Hi, welcome to Detours Understanding Acquired Brain Injury. This is Thunderstorms of the Brain, classification of seizures and epilepsy. When it comes to communicating with professionals and between each other as well as with families, loved ones, we need a way to talk about diseases and disorders of all sorts. But when it comes to any study of a disorder where our knowledge continues to expand and to grow, so this is especially true when it comes to diseases and disorders of the brain or anything where we really don't know a lot, we need to have a well-constructed system of classification. And fortunately, the International League Against Epilepsy has done a good job in keeping the system up to date. Although these updates and changes do take a while to percolate through to different levels of providers, families, things like that. So what we're going to do is we're going to talk about how they classify seizures, and then we're going to talk about how they classify epilepsy. Also, we're going to have a separate section where you can click on, these will be really short, on different epilepsy type disorders, familial and ones that come along with developmental disorders too. But that will be separate. Those will be like 15 seconds or 10 seconds worth just talking about what the condition is. It may include some images or something else like that, but that's separate from this. That'll be more supplemental material. All right, so let's get into the International League Against Epilepsy's definition of seizures, which they created in 2017, which is the most recent version. So first of all, they've grouped seizures into three types. They're localized, which are seizures that start, which is the emphasis of this system, where the seizures start in the brain. Localized, which start on one side or the other of the brain, but do not propagate across to the other side. So localized. And then there are generalized seizures, which originate both sides of the brain. And then there are unknown onset, where they don't know where they're coming from. They may come from deep down, they may come from both sides. And finally, unclassified, where there's not enough information. Maybe they don't have access to an EEG wherever they're doing this or whatever. So then within focal onset and generalized onset, all of these, there is aware and impaired awareness to classify. Now, the thing about this is it doesn't mean unconscious. It just means that the patient can't interact so their eyes may be open or they may be making sound, but they can't interact with the person doing the observations. So impaired awareness or aware. If they're aware, obviously they can interact, but maybe they can't control a part of their body, or maybe they're staring and they can only say a few things. So, all right. And then finally, within these categories is motor onset. So the seizures start with motor symptoms, that is movement, or they're non-motor. And by this, we could mean all kinds of different things. We could mean that they're sensory or emotional symptoms started, or cognitive symptoms start, or kind of changes with behavior, but not necessarily motor. And it's the same thing for generalized and unknown onset, of course. So let's start with focal and talk about motor onset. So one side of the brain with motor changes. All right, so what can these look like? Well, first of all, the very first one would be atonic. So focal, one side of the brain, atonic, where they suddenly will lose tone, muscle control on one side of the body. or will lose, control one limb or, in their legs. But that could be dangerous. They could fall down because of it. Tonic, which is sustained focal stiffening. So, their hand may become tight or foot, something like that. They may have some kind of stiffening. They may have clonic, which is focal rhythmic jerking, something like that. Or they may have myoclonic, which is irregular brief focal jerking. They may have, something on the eye or their face or something like that, like twitches kind of thing. They may have epileptic spasms, focal flexion or extension of arms or flexion of the trunk. And so, these are kind of the things you would notice. And it can be hard to tell the difference between clonic and myoclonic since it's somewhat arbitrary. But clonic does imply that it is sustained for a while, and they're regularly spaced, the stereotypical kind of jerks that you would see with epilepsy. Other less obvious focal motor behaviors are hyperkinetic, like pedaling of the legs or thrashing around, and automatisms, like picking at a button or, chewing or sticking your tongue out, things like that. If you're an observer and you see this kind of thing, you may be asked whether the patient demonstrated repetitive, purposeless fragments of behaviors that might appear to be normal in other circumstances. These are what the automatisms are. They might be part of something you would do otherwise, but they're just a piece of behavior, and they would overact. It's like they overlap, with other behaviors. For instance, the pedaling or the hyperkinetic activity, they may walk around kind of purposeless. And it's sometimes hard to tell where that fits. It's like, is it hyperkinetic? Is it just like disconnected movements? Or is it more like a rhythmic kind of jerking? So automatism versus hyperkinetic behavior. But you do see either one of these within focal seizures. But you also can see them in absent seizures, which are more generalized type, and that just adds some of the challenges. A focal motor seizure with behavioral arrest involves sudden cessation of all movement and unresponsiveness. Because brief behavioral arrest happens at the start of many seizures, it's common and it's more challenging to identify. A focal behavioral arrest and seizure should comprise behavioral arrest as the predominant aspect of the whole seizure. Now, that should be what you see throughout the whole kind of seizure. And so that will tell you that is really what that seizure is about. It's like a focal seizure with behavioral arrest. Focal autonomic seizures present with primary changes or other autonomic effects, including potentially behavioral arrest. So focal cognitive seizures, this is the non-motor type, can be identified when a patient reports or shows deficits in language, thinking, associated higher cortical functions during seizures. And if these are the predominant symptoms, this tells you it's cognitive. If they have deja vu or jamais vu, where they either feel like they've been here or done that before, or familiar things suddenly are unfamiliar, that's jamais vu, the opposite of deja vu. If they're experiencing illusions, which are distortions of objects, if a pen distorts into a snake, or if a familiar voice becomes a scream in their mind, or if they see things that aren't there, if they see a room is dark suddenly, or if they see demons or whatever, this would be an element of cognitive seizures. Impaired cognition, can be assumed, especially with altered levels of awareness. Focal emotional seizures. This describes both a crying or laughing gelastic seizures or dichristic seizures, but it's like they don't have to feel that way. And many times it's not mood congruent. But sometimes they will also subjectively describe being sad, happy suddenly. It's like a sudden shift of mood because the seizure can affect the emotional centers, the limbic centers of the brain as well. Also, focal autonomic seizures are those kind of seizures that affect, heart rate, blood pressure, respiratory rate, cause it to spike or to be suppressed, causing palpitations, sexual arousal, respiratory problems. Other autonomic systems may cause nausea or vomiting. Pituitary changes even, although that's a little more subtle, but still. Then, those kind of things. Just want to check something here. So one of the things to do here is you do need to verify whether there's awareness or whether there is a loss of awareness, because in the case of emotional seizures, the patient may be aware and just can't explain why they feel that way. In other cases, they're not going to be able to respond to you, so it may also involve cognitive faculties. But again, these tend to be focal in nature. There may be other kinds of focal seizures where you get tonic-clonic seizures, which look like the more traditional types of seizures, but they don't often happen enough like this where to classify them. So just so what about generalized seizures? This is the other kind where it's both sides of the brain. This is the classical, typical, like fall to the ground, have the initial tension in the body and stiffening of the limbs, then have the convulsive jerks. The tonic is the stiffening side of things, and then the clonic is the repetitive jerking motions in limbs and in the trunk and the head back. And there is a loss of awareness here. The terms motor and non-motor do apply, but really the onset again tends to be motor here. The tonic-clonic has replaced grand mal, the traditional grand mal, but it's pretty much the same idea here. There are other kinds of generalized seizures with motor symptoms, such as atonic, the traditional drop attacks where somebody will just collapse to the ground. These are ones that are dangerous, and you need to make sure you protect somebody's head if they have that kind of seizure, that kind of generalized seizures. So you can also have just tonic or just clonic generalized seizures, where you have stiffening and it lasts for varying amounts of time, a few seconds to a minute or two typically, or just a clonic where you've got the rhythmic jerking. So epileptic spasms, they used to be called infantile spasms, and what's important about this is that it can be a red flag for potential future developmental problems. So it's just being aware. You can see the sudden flexion or extension or mixed extension and flexion of the limbs and the trunk. These commonly occur in clusters in kids, and they are something you see in infancy. Generalized seizures, again, both sides of the brain, where they're non-motor. Again, not as common, but you do see them sometimes. In EEG, they tend to be the absent seizures, the staring seizures, where you may get like the few blinks, and these may happen dozens, even hundreds of times a day, and just like there's no awareness. And this is one of the key features that marks the difference, is that they may just stare and blink, or they may like pill rolling, this kind of stuff. So that's an absent seizure. Again, they may fall in some cases. Typically, these last for about 10 to 60 seconds. And it may not be obvious that they're not aware, but you can see there's like no awareness in the eyes. So just being aware. Eyelid myoclonia, which are myoclonic jerks of the eyes. This stands out, and usually the eyes roll up back. So usually this could be triggered by light. It's different from absent seizures because it's just with the eyes, but they also can be strictly a motor symptom. So usually you have to differentiate with an EEG. And in a lot of these where there's a tremendous amount of overlap, an EEG will help differentiate, plus careful observation, which is why patients with many of these end up needing to go to an epilepsy monitoring unit so you can differentiate the different types. Because there are also absent seizures with eyelid myoclonia, where you get both together and differentiate that. Again, the EEG will help differentiate, and photosensitivity, being the triggering mechanism, is what can help tell the difference. And you may see this as Jevons syndrome, which is a seizure type disorder there. So just understand that every seizure classification involves some degree of uncertainty. And so these tell you about an 80% likelihood that it's either focal or generalized. Otherwise, you have to list it as, unknown. So 80% is good enough to say, okay, this is yes, no. So what about epilepsy syndromes? An epilepsy syndrome refers to a cluster of features which are incorporated, which incorporate seizure types, EEG, imaging features, all those kind of things together. Usually it's age dependent, so you'll see certain types of epilepsy syndromes at different ages. Some emerge during infancy, some during childhood, others at adulthood. It may have comorbidities with it, other conditions that pop up. And so you need to know like a variety of other factors in order to make this kind of determination for the type of epilepsy. Because epilepsy types are defined like seizures, where it's focal or it's generalized, or combined generalized and focal, or whether it's unknown. And so, what kind of etiology? Is it a structural change in the brain? Is it, a genetic factor for the epilepsy? Is it due to an infection of the brain? We talked plenty about those. Is it metabolic? We've talked about that too. Is it due to diabetes? Is it due to something along those lines? Is it an immune inflammatory type reaction? Something like that. Under structural, obviously you have things like strokes, traumatic brain injury. You have the cortex may have developed in a peculiar way, or down to the cellular level, and we will get into this stuff when we talk about the neuropathology, may have developed in a way that wasn't, in an altered way. And you see this with genetics, or the electrochannelopathies, where the cells themselves have some specific changes in how standard development goes versus those with some kind of disability, that maybe the channels aren't functioning right that conduct for the electrical charge, or the receptors inside the synapse aren't functioning right. And so there are a lot of reasons why. The truth is, anyone can seize under the right circumstances, but there are certain things that lean a person in one way or the other. That's why EEG is so critical in helping making these diagnoses. Individuals with generalized epilepsy, this is something else to understand about classification, is that they may have a range of different seizure types. They may have absence, they may have myoclonic, they may have atonic, tonic-clonic seizures, a whole bunch. And so again, complicating the classification, and so it's easier just to simply say they have this syndrome, and that syndrome contains root flexibility for those types. So certain types of epilepsies are self-limiting, which means, when it starts in childhood, it may go away over time. Or there may be different kinds of conditions where epilepsy is only one of the parts of, it may include intellectual disabilities, visual problems, and it's just one element of the entire condition. Some epilepsies, and this is based again on the diagnostic criteria, are very sensitive to medications. Others are resistant and need other treatments. So it's just something to keep in mind in relation to that. The term unknown, as I'd said before, is used to denote where it's understood that the patient has epilepsy, but the clinician cannot determine, if the epilepsy type is focal, generalized, any of those kind of things, because there just isn't enough information. Maybe nobody ever saw them have, saw them start. There are nocturnal types of epilepsy. Maybe they never saw them have or start a seizure. And that's one of the weaknesses of this classification system. All right, so this is the general classification system, basically in sum: focal, generalized, focal to generalized, unknown, and awareness or impaired awareness, and motor, starting with motor symptoms, and non-motor. And as I said, there will be a separate section where you can look up specific disorders, where we will give a few seconds of each, where you'll get to see EEG and MRI if I have them, if I can get them, and then it'll talk about the primary symptoms associated with the epilepsy syndrome, because there are a lot of those, and that'll be available just to hit that and say, oh, this is the kind I have. But I did want to give a brief overview. Next, we'll talk about the specific causes. Mostly, a lot of it is still, some of it we know for sure, like due to brain injury or, genetics. Or at genetics, I don't mean that the parent has it or grandparent had it. Oh, your genetics are terrible. No. Many of these genetic disorders are what's called de novo, and that means it arises spontaneously, just due to a change in a gene sequence somewhere. That happens, and that's a majority of those that are, and a majority of people have that genetic change. It doesn't take much to make that kind of change. Okay, so if you have any questions, comments, please leave them below. Please click like, subscribe, don't forget the bell icon, and we'll see you for the next episode of Thunderstorms of the Brain, and when we talk about neuropathology, to help you understand a little more about the mechanics behind it, because it is interesting. And epilepsy is kind of a network disorder, as in different brain regions involved, as well as at different levels, from the cell all the way up to the organism. So hopefully you'll find that fascinating too. And see you later.